Risk scores are everywhere in hospitals. They quietly influence decisions from the moment a patient is admitted through discharge planning and follow-up. In many cases, clinicians rely on these scores to decide who needs immediate attention, who requires extra monitoring, and where limited resources should go. These scores are more than just clinical tools. They're deeply embedded in EHR workflows, integrations, and system logic, relying on data from vital signs, clinical documentation, test results, medications, and the patient's coded problem list. For health IT professionals, understanding more about these scores will help you support safer workflows and stronger collaboration between teams. Today, I'll walk you through 6 risk scores that you're going to see in most hospitals, focusing on what they represent, what types of data they require, and where you're going to come across them in the EHR. Before we jump in, if you're new here, my name is Dre. I've been working in healthcare for about 25 years, and with the last 19 of those have been focused on health IT. Okay, let's kick things off with sepsis and early detection scores. Sepsis alerts are designed to identify patients who may be developing sepsis before the obvious clinical signs appear. Some organizations will leverage screening tools like QSOFA, while others will implement more complex models that are continuously looking to the EHR anytime new data is added. Common inputs would include vital signs such as temperature, respiratory rate, heart rate, and blood pressure, as well as certain lab results and information that's added to clinical notes and flowsheets. From a health IT perspective, these scores only work if the right data is included and it stays reliable. That means working with clinical teams to confirm the inputs, set up patient-level alerting, and to work on centralized dashboards that are going to identify these pre-sepsis patients across multiple units. Another common category that you're going to see are early warning scores. These are meant to answer a simple question. Is this patient getting worse? Muse is one that's commonly used in adult inpatient units, while Pews applies similar ideas to pediatric populations. Instead of looking for a specific diagnosis or event, these scores are set to look for small changes that suggest a patient might be headed in the wrong direction. Things like rising heart rate, falling blood pressure, faster breathing, lower oxygen levels, or changes in alertness. If a patient's early warning score increases or reaches a specific threshold, the system can prompt specific actions like closer monitoring, contacting a provider, or activating a rapid response team. Some organizations also choose to integrate these early warning scores into nursing and provider communication systems to help ensure a timely response to the emerging risk. Early warning scores will tell you when a patient is starting to decline, but once we get to intensive care units, the focus shifts to understanding how severe that illness actually is. Scores like SOFA are used to assess organ function across multiple systems, considering things like respiratory function, cardiovascular stability, liver and kidney function, coagulation, and neurologic responsiveness. And scores like Apache 2 will build on that by incorporating physiologic measurements, diagnostic test results, age, and chronic health conditions to estimate mortality risk. Both these scores pull from a wide range of data, including lab results, medications, active diagnoses, and structured clinical documentation. From a health IT perspective, collaboration with these ones is really important because application analysts working across several different modules will need to make sure that all of these inputs are configured correctly and maintained so that the results will display accurately on ICU dashboards, and they can be used to support clinical triage decisions, prognosis discussions, and care planning. You definitely don't want to have conversations with families if the mortality risk score is pulling the wrong number. So we've talked about some pretty big heavy hitters so far, but not all risk scores in the hospitals are about how sick a patient is. Some of the most common ones that are used focus on everyday safety. Fall risk scores are used to identify patients who may be unsafe to move on their own. They look at factors such as prior falls, mobility or gait limitations, confusion or cognitive impairment, and the use of medications that may impact balance or alertness. Tools like the Morse Fall Scale or Hendrick 2 convert these factors into a numerical score that drives prevention strategies. Fall risk scoring is tightly integrated with nursing documentation workflows, and higher scores often will trigger visual indicators within the EHR. This helps ensure that the entire care team is sure of the increased risk and can take practical steps with the patient to prevent a fall. Another one that is commonly used that is focused on day-to-day care is pressure injury risk. These scores look at a patient's ability to move, sense discomfort, and maintain skin integrity, all of which affect how long pressure may remain on one area of the body. The Braden score is one example, and this one considers mobility, activity level, sensory perception, moisture exposure, nutrition, and friction or shear risk to estimate the likelihood of a skin breakdown. When a patient's score reaches a high level, systems can be configured to trigger prevention protocols, such as scheduled repositioning, specialized support surfaces, and additional skin assessment requirements. Pressure injury risk scoring often connects nursing workflows with equipment coordination, staffing considerations, and quality reporting. It's a good example of how a single risk score can influence both clinical care and operational planning. The last one that we'll look at today focuses on a patient's readmission risk. These scores are used to estimate the likelihood that a patient will return to the hospital within a defined period of time when you're not expecting that they would need to do that. Usually that time frame is around 30 days. They consider factors such as prior admissions, number and severity of chronic conditions, length of stay, medication complexity, and when available, social and functional considerations that may impact recovery at home. Rather than being predictive for its own sake, these scores are meant to support better discharge planning. They help care teams decide where additional education, coordination, or follow-up may reduce the chance of an avoidable return. From a systems perspective, readmission risk often spans multiple places. It may pull from inpatient data, case management documentation, scheduling workflows, as well as external care coordination tools. In many regions, these readmission rates are used to evaluate how well transitions of care are supported, which makes clear definitions, transparency, and appropriate use of these scores especially important. Risk scores may show up as numbers on an EHR dashboard or a clinician's patient list, but they shape clinical decisions every day. Who needs attention first, which safety steps are needed, and where teams should focus their time and resources. For health IT professionals, understanding which risk scores are used in your organization, which areas of the EHR they're going to pull from, and how they're going to display so that they can support care delivery is really important for that broader picture. These tools only work when clinical workflows, data quality, and system design stay aligned. Whether you work on orders, ClinDoc, reporting, or integration, risk scores are a shared responsibility and they require a lot of collaboration with clinical counterparts. But when all the teams work together, they support safer care, better coordination, and more effective use of resources. That's all we have for this video. I hope you have a great rest of your week.